everyone, it's Dr. Towfigh. Welcome to Hernia Talk Live, our weekly question and answer session. I'm here and we're having problems with Facebook, I think because of all those issues from the weird Microsoft thing that happened online all over the world last week. But I'm very happy today to be joined via Zoom only, not Facebook Live this time, with Juan Salazar. So Juan is a certified surgical technologist. I've known Juan for
9 years, close to 10,
close to
2015.
like 2015. Okay. So a little over 10 years, almost 10 years. I'm just really excited to have you on. So this is the
Thank
story.
you.
Let's start this over. This is the story. So Juan knows I've been doing these Hernia Talk live sessions, right? And every week I'd be talking about what we've been talking about, the topic, questions and answers, and so on. And we talk a lot in the operating room. And recently, Juan has made a move to a different hospital. So I haven't been with Juan. And I get this message, and Juan's like, you do this great stuff on Hernia Talk Live. Why don't you do like a behind the scenes sessions? Because so many patients go to surgery and they don't really have a good kind of concept of this big black box called the operating room, right? And I'm like, that's exactly right. Why don't you be my guest? So Juan is joining us from Arizona. He's
Yeah.
at a major hospital in Arizona. He used to be the surgical tech at our surgery center, which is where I do the majority of our hernias and hernia-related mesh removals and things like that. Juan has seen it all. And I love Juan because he's very intelligent. And I'm very attracted to people that are intelligent because I can talk to them. And if you're spending time in the operating room, it's really, really a gift to have someone that's intelligent. I've learned a lot from Juan. And so
As I've learned from you.
welcome to my show. This is so exciting.
I'm excited to be here.
So you can follow Juan on Twitter or on Instagram. He is on Instagram at Surgery Tech 84. So it's actually SX_TECH 84. He's very funny. He's got a lovely family, 4 kids,
4 girls.
all girls. God's trying to tell you something.
God told me something, and I saw Josephson for that.
Yes. Dr. Joseph was one of our guests. Snip, snip. So,
Hmm.
so we were just talking, quote, backstage before we went live, and then Facebook decided not to like me today. So we can't do this as a Facebook Live, but I'll make sure this gets posted on my Facebook page for everyone else to see and share, in addition to YouTube. But the goal of today is to help figure out everything that you need as a patient to learn about kind of demystify, is that a good word? Juan,
Yeah,
demystify what happens in the operating room.
most definitely. Yeah, it's not a big secret, which is people really don't know. Once the versed hits, they don't remember anything. They just remember like, oh, this is really nice, and then oh, I'm awake.
Well, so that's important because the the surgery starts in the operating room, but the patient care starts preoperatively, right? So
Very much
depending
so.
on whether it's a hospital or a surgery center, it's still the same. You go to a preoperative area, you unclothe down to, I mean, pretty much everyone's completely naked. We don't have
Yeah,
like underwear and socks and so on allowed. Um, you're given a gown, and then after you see the surgeon and the anesthesiologist, then you're whisked into the operating room. In that space, there's no family members, no one can watch you. It's purely the surgical team. During that transport, you're often given a medication called Versed. It's an amnesiac.
amnesiatic.
Amnesiac. So
Yeah,
you should not remember anything once you're given that drug. It also calms you down. But it's so interesting because we remember you in the operating room talking to us even, right?
Oh, full conversations about what's going on in their lives, like complete conversations, and they're usually very funny
But
patients most
patients
of the
have
time.
no idea. They don't
Yeah.
remember any of it.
Well,
Isn't that interesting?
because of my role, I don't get to see that part at the end. I just get to see them kind of wake up and get whisked off, and then I'm cleaning the room for the next case.
Well, part of the role of the anesthesiologist is to make sure they don't recall anything during surgery and then hopefully nothing before and right after. Because for some people, it can be stressful
Could be traumatic.
and traumatic. Yeah. So, okay. But okay, so what's the protocol? The the nurse usually with the anesthesiologist takes the
The
gurney
patient. Yeah.
with the patient to the operating room, and then there's other members of the team in the operating room. You're one of them. You're already
Yeah.
there, usually scrubbed in and waiting, right?
Well, what we do is my role begins usually
Before,
days
days before. You're
before the
like the
surgery
Secret
starts.
Service. You're the one that goes in and makes sure everything's ready when
Exactly.
the president
So
shows up.
like day of surgery, I usually go in there an hour before my first surgery begins. Let's say I'm doing a hernia with you. We start at 7 in the morning. I'm usually there by 6.
Yeah, or
I
sooner.
go in
Yeah.
there. I go in there, I make sure the room is set up, make sure we have the correct instrumentation that as far as like the correct bed, the correct towers, the correct,
Yeah,
you
even
know,
the correct bed is important
yeah,
because
very
some
much
beds,
so.
right?
Yeah.
Beds are different depending on the type of surgery patients need.
Yeah, and then how you set it up, because you can set up the bed backwards so that you can actually like flex the bed a certain way, tilt it or whatnot.
Yeah.
So the bed is one of the main components there,
Mm-hmm.
aside from the actual video equipment, the cameras, the towers, things like that.
Because some beds you can do fluoroscopy with, others you can't. Some are
Exactly, because
longer, right? And some are not. And
some,
then
yeah, so
some you
and
need to put the patients in a special lithotomy position. So you need
yeah, so you
special
would need
attachments for
the
that.
special stirrups for that. But those attachments can attach to basically almost any OR bed.
Yeah.
But yeah, you have to make sure that I have to make sure all that is there, and then I go and actually check the list of things that we need as far as our instrumentation, if it's sterile, if it's not sterile. Uh, Most of the time we check to see if we have the correct mesh, if it was ordered, if it was there. But we do that in conjunction with the nurse.
So I usually
Then
tell you in my communicate with the operating room in my orders specifically what mesh I want. And I
exactly.
do that both for the surgery center and the hospital for two reasons. One is it kind of reminds me what my train of thought was in planning for the patient when I first saw them, but it also somewhat guarantees that the surgery center or the hospital carries that mesh, is not out of stock or doesn't have the right
Or,
size or things like
or if
that.
they had to order it, they did.
Yes. Yeah,
Yeah.
sometimes they have to order it.
And like most of the time, especially at an ambulatory center, they do have to order it depending on where you're at.
Yeah, they don't have a
Yeah.
large variety or a large inventory because it's expensive.
Right. And I mean, some places do have a what's it called? They do have somewhat of variety, but minimal amounts of it. So if another surgeon order it before you did, well, they're gonna save it for that particular surgeon instead of for you when you didn't order it. So and that plays. I don't know why it does play a big role because that the other surgeon ordered it and you didn't. You just assumed it was going to be there, which is why sending orders ahead of time is such a big help for everybody.
Yes, I feel most surgeons do not order their mesh,
Mm.
right? Because you operate with other people who do hernia surgery.
Yes, yes, and they most of the time they ask what mesh do you have,
Mm-hmm.
not hey I need this mesh or hey I ordered this mesh. No, they just ask, hey, do you have this mesh? I'm like, sure, give it to me, give me some scissors, I'll cut it to whatever size I want.
Mm-hmm.
Uh,
Some meshes are not supposed to be cut. That was one of my
yeah,
first cases that I did. Yeah,
yeah,
where
yeah.
the
I
surgeon
remember,
cut a mesh that shouldn't have been cut.
yeah.
Yeah.
Oh, then when they put it in and they use the ProTac or whatever it is that they're using, I've seen them use it incorrectly. Like we did I assisted in an laparoscopic umbilical hernia.
Okay.
Put in the mesh that they wanted. They had the correct size, about that big, and then they
Yes.
proceeded to put a tack
Every 0.1 millimeters?
Yeah, we went through 2 tacks
Two for, oh, wow.
for something that big. As
Yeah.
big as my face. That's there shouldn't there have been like a couple inches in between space or
Yeah.
something like that?
Yeah,
No,
pretty much.
all the way around.
Made them feel better, but that really pushes the patient into severe muscle spasm at the
Yeah,
least, at the
at the
least.
very least. Yeah. So
Yeah.
and then we talked to the rep, was like, aren't you gonna say something? Because this is your stuff. And they're like, no.
Yeah.
Yeah.
So, okay, so let's review who's in the operating room. There's obviously the surgeon. The
The
surgeon
surgeon.
may or may not have a surgeon assistant or
Yes.
some type of dedicated assistant. Sometimes they're nurses or physician
Uh,
assistants.
yeah, it
There's
was a
you
PA
have
and
to be
everything.
there. You're
Yes.
you're the surgical tech. Now, before your generation of surgical techs, there used to be nurses that were doing the surgical
Well,
tech job, right?
my profession, it was before the schools started popping up. It used to be an OTJ
What's
trained position,
OTJ?
on the job training.
Uh,
So you got brought in and you got trained by a surgeon on how
uh-huh.
to do things. We didn't have schools. We didn't have a curriculum to follow.
Okay.
They just pulled you in. You want to learn? They pulled you in and you started. They taught you from zero. And I know, I still know techs that that's how they started.
Wow.
They started as they got trained on the job, and
Now
then
there's a
later on.
certificate. Now there's a certification for surgical technologist.
Well, now there's an associate's degree attached to it, and if you and in
Oh,
Texas, there's actually a bachelor's degree that you can get,
wow.
but only in Texas, nowhere else.
Hmm.
Yeah.
Okay. So, so what's the process? You have to you have to get a high school diploma first,
Yes, you have to get a high school
and
diploma
then
first. You have to go to you can either go to uh a JC, a junior college,
okay, junior college.
and they have a curriculum there. But with that curriculum, you don't get an associate's degree. You just get your certification,
Okay.
and that particular process lasts for about 2 years, 2.5 years.
Okay.
You can go to a an accredited like a tech school, like a trade school that has
Mhm.
the which is what I did. I went to a trade school. And it's 9 months, depending on the trade school. The one I went to, it was 9 months of classroom training.
Mm-hmm.
So I was on like taking tests, learning the pharmacology, learning uh instrumentation, everything. Then you go into your clinicals. And with us, at least when I graduated back in 2010, in my class, we did 3 months of central service. So that's where we learned all of our instrumentation. We
Oh,
learned how to
so
wash it, how to take care of it, how to sterilize it, how to wrap, sterilize, and how to make sure everything was okay for the surgery.
so in addition to your work in the operating room, which is assisting the surgeon in handling, you're basically the communication between the non-sterile world and the
And the
surgeon,
sterile, yeah,
right?
yeah,
The
pretty
sterile world. You are sterile, and most of your work at the time of surgery is handing instruments and providing needles and scalpels and so on.
making sure though, so the whole field, sterile field is maintained sterile.
Right. You set up the sterile field and
Yeah,
you're also in charge of maintaining it. So
yeah.
if there's
And when
anything
you
that you
have
see going wrong, you're the one that usually picks that up.
Yeah, when you have like new residents coming in and things like
Mhm.
that, and they have no idea how to do it, and it's happened to me where I'm setting up an X lab, uh, just an open procedure,
Yeah.
and a new resident comes in and he's like, "Hey, do you have my gown and gloves?" I'm like, "I have no idea who you are,
Yeah.
but the gowns and the gloves are there." So
Yeah.
they go grab the gloves and they're like, "Okay, you can throw them on the field if you want," and they literally toss the whole packet on the field. They don't open
Oh
it because
no,
they
the
contaminate
unsterile
my
packet.
field.
Oh, that's happened?
That's happened to me. That's happened
Oh
to
my
me. And
God.
I look at my like, and it
Mm.
lands right on my instruments.
Oh,
Not even like a place where I can kind of like cover it up and with a tegaderm or something like that. No, like right
oh,
on my instruments. And I just look up and I look at the guy, and look at the resident, and I'm like, did you really just do that? Like he
Oh,
had no idea
wow.
what sterility was. Well,
Yeah,
I'm assuming that thought he would, yeah.
there's a whole protocol and process about what's sterile, what's not, which
Very
parts
much
of
so.
your sterile area is truly sterile, what parts are not so sterile.
Yeah. What
Wow.
you can,
My
yeah.
God.
So, so when that happened, I just turned around and stared at him. I turned around, looked at the surgeon, and the surgeon just looks at him, tells him to get out of the room.
Oh
And we have
no.
to, obviously, at that point, we have to break everything down. It delays the surgery again because now
Restart,
we have
start all
to
over.
start from scratch again. We have to open a whole new, like a whole new sterile field on our table,
Yes.
open up sterile instrumentation again, do all our counts all over again, open up
Yeah.
basically everything again. And it's not only timely, it's costly because now we're
Yeah.
spending much more money to reopen everything again. And if we
And then
had
in the
any,
backside, you got ways of sterilizing, cleaning, packaging everything,
yes,
autoclaving. There's a whole sterility process that there are companies that come around to audit you to make sure that your sterility process is done correctly.
yeah, we have the Joint Commission, we
Mm-hmm.
have CMS, we have a lot of they literally they like every 3 years they're like on us,
Yeah.
and they are
Surprise.
nitpicky. They are like comes to like the smallest little detail,
Mm-hmm.
completely nitpicky, and
Yeah.
it can get frustrating with them when they're in house.
Yeah. So other people in the operating room, usually the anesthesiologist or anesthetist, could be a
Mm-hmm.
doctor, it could be a certified
CRNA, yeah.
nurse anesthetist. Um, and then
There's a
there's a
circulator.
circulating nurse, right?
Mm-hmm.
So that's pretty
And
much in the United States, that's pretty much minimum. In third world countries, there's maybe less than that.
yeah,
Um, there may be one anesthesiologist for multiple rooms. There may be non-nurses that
and,
handle things.
and I've noticed that also goes, it changes from state to state.
So yeah, so you experienced California, then you went to Arizona.
So here where I'm at the hospital where I'm at, we do have nurse anesthetists, we have CRNAs,
Yes.
but they can't put the patient down unless the MD is in the room, unless the anesthesiologist is in the room.
The
And the
hospital does
anes
that. Yeah.
yeah, the anesthesiologist it has to be the one literally looking over the shoulder as they put them down.
Yeah, they
And
function
I
more
was
like
like,
residents than actual
no,
independent anesthetists, right?
no, it's CRNAs. Like CRNAs with like 20, 30 years of experience. They still have
Yeah.
that anesthesiologist right next to them, making sure they're doing it correctly. And most of these CRNAs that have been there for so long, they know more than some of these anesthesiologists, but
Yeah.
because of the laws, they that's what they have to do.
Yeah, I asked about that. I didn't understand it because at the surgery center and at some hospitals, the nurse anesthetists are very independent. There's no
Yeah.
doctor around that's an anesthesiologist necessarily, but they're like at the hospital, they're treated like a resident. The attending surgeon has to be there overseeing the initiation and the termination of anesthesia. And I
Which is
think
weird.
it's a billing issue in addition to a safety issue. I think some there's a level of anesthesia maybe that they negotiate a contract with the insurance company. I don't know.
It could be at that. I have no idea. Yeah. Because I
I don't
mean,
think it's just a policy.
because over at the surgery center, it was a CRNA was head of anesthesia.
Yes, it still is. Yeah, it still is.
Yeah.
And they
So
do
it's
great. Patients are
yeah,
great.
yeah. I mean,
Yeah,
I don't know if you remember Robin Rabani, like CRNA
fantastic.
just ridiculously good, and he's the one that taught everybody there how to do blocks.
Yes.
Only
Yeah,
got him into the
exactly.
block system. Yeah.
Yeah, yeah. So yeah, that's kind of interesting. There may or may not be a rep in the room, an industry rep. That's
Mm,
very dependent
That
on the surgeon and the procedure and the
what
hospital
disposables you're going to be
policies,
using.
right?
Yeah.
What'd you
Like
say?
if you're going to use any of their implants, you definitely want to rep there.
Well, the implants for orthopedics and neurosurgery, right? Am I correct in
Yes.
that?
Yeah, you're correct. You're correct.
And
For
why
usually
is
for
that? Because they have so many different pieces, or what's the reasoning for that?
there is so the word with orthopedics, there the components Like let's say for a total hip, they bring in, at least at the hospital where I'm at, they bring in the trays like the night before or 2 days before, so we can sterilize them, have them ready. And then the implant components actually they come together before they go into patient, and then we have to cement them to put them inside the patient. And
Mm,
sometimes either the surgeon needs a little help, or even us, the techs, we need to find out how to do it. And if we've never used that system before, we need the help from the reps and their
mm,
trusted lasers to let us know how to put things together. And it is immense help. I mean, even if we've done it 100 times, the rep being there gives us a sense of ease. It,
yeah, it's very complicated. They keep changing it. Yeah.
and
Like
yeah,
the
the surgeon.
iPhone, every year it's like a new one, so you need like a specialist.
Yeah, right. Yeah,
Uh,
so yeah, we definitely need a specialist to let us know. And
Here's a
then
question. What is a tack and what is it made of, and what is the advantage over sutures? So there's different types of tacks. There's a permanent and the absorbables. The permanent
yes,
is titanium based, and the absorbables are usually suture based,
like
like
a like a
PDS, like a
PDS or a
PDS.
Vicro. Yeah.
Yeah. But you want to explain what it looks like, these hernia
So the
slash tacking devices?
so the ProTag, which is one of the more widely used one,
Yeah.
it actually it looks like a spring,
Yeah.
like a small little spring, diminutive, and it like corkscrews in through the mesh, which doesn't rip the mesh, which is even better, and then
Yes.
it goes into the
Yeah,
soft
I like those the best. It's the old
tissue.
school
Yeah,
one. They changed the not changed. They added absorbable ones, which a lot of surgeons use the absorbable meshes. I mean absorbable tacks,
stays.
but
Yeah,
I don't use absorbable sutures. I don't see the purpose of absorbable tacks. It's just much more expensive.
yeah, and then I think I've read of instances where patients actually develop an adverse reaction to them.
Oh, yeah, yeah.
It's not
It depends
common.
on how it's used. Yeah, depends
Yeah.
on how it's used. Not common. Yeah. So okay, you can be honest. Who's the best hernia surgeon? I'm just kidding.
And I'm not realistically, because I worked with you for so long and I've seen how quick you are and how good, how what is it called?
Careful.
How much you pay attention to detail when you're doing your surgeries
Yeah.
compared to some of the other surgeons I've worked with. By far, you are probably the best that I've worked
Oh,
with.
thank you. Well, give an example. Give an
Oh,
example to maybe give a little bit more
yeah, so I work with
clarity.
this. I work with this one surgeon who were doing ventral hernias.
Hmm.
He decided to go open, which is fine. I mean, I don't know. I didn't know why. He still used a spacemaker. So he put in a port on one end through the spacemaker, pumped it up, and that separated the ventral hernia from the rest of the tissue. Or I don't know
Okay.
what he did.
All right.
And then it made it easier for him to see where it was at and to fix it manually.
Oh,
Interesting. But then he popped that on accident,
oh.
and he had to do the other side, and he opened another spacemaker. And those things, as you know, they're not cheap. They're expensive.
They're $700-800 each. Yeah.
And we used two of them for a case that took 45 minutes.
Let's see. The space maker, but then he went open?
Yeah.
Hmm. Because
I
I know
I will
using
find out
space
exactly.
makers on the left and right to do a component separation, but there's no reason for it.
Hmm.
I mean, there's different ways of doing things, I guess.
Yeah, and he learned it from somebody else, and he's like, "Oh, it's amazing! It just makes surgery so much easier, so much faster, which is great. But at what cost? And at what
This
cost to the
is
patient?"
true. This is true. And you've seen me
Hey,
kind of make
I
comments
I I
about that.
I have advocated for the toe finger at my new job. I've
Did
advocated
you
about
call
it.
it that?
No, it was another tech that when we did the live surgery, a few years ago. His name was Jeff, and he's the one that
Yes.
called it the toe finger because I think he saw you do it, and then he taught me how to do it, and then we were just that's what we called it from then on. Like it's a toe.
Okay. Uh, but did you call it the toe finger at your new hospital?
Oh yeah, oh
No
yeah,
way.
yeah, yeah. I was like, I told him, oh yeah, we instead of using these space makers, what we do is like we get a couple of gloves, couple of old ties, get a suction irrigator, and just like blow it up,
And,
and it's so much cheaper, and it's like, and I called it, I told him we call it the toe finger because of a doctor that used to do it. Her name is Dr. Towfigh, and
and you
it
use the finger
works.
of a glove.
Yeah, and well, we use two fingers, so I mean,
Okay, so did they think that was crazy? Or did they think, oh, that's a
one of the
nice cheap
surgeons
way?
was like, no, no, one of the surgeons was like, that's actually genius. That's pretty smart. And he asked, like, how much like saline do you guys use or anything like that? I was like, if I remember right, we used probably about 60 cc's and then we just suck it out.
4 times.
60, I was 60,
Times
80
4.
cc's. Yeah, so 80 cc's.
Like 240 cc's.
240? Oh yeah, because there's
Yeah.
big, yeah, yeah, right. It's about
Yeah.
240.
It
That's what it
says,
says.
here's a question. Is the space maker also what is used to do the retrorectus dissection in laparoscopic TEP, inguinal, or hernia repairs, or is that another device? Yeah, yeah. So the space maker was intended to make a retrorectus space for the laparoscopic TEP, inguinal, hernia repair with mesh. It has since been expanded for any retroperitoneal procedures. So some people use it for the kidneys to access retroperitoneally and do a laparoscopic kidney surgery in the retroperitoneal space. There have been reports of using the spacemaker to make a lateral dissection to do a minimally invasive component separation for ventral hernias. But I've never heard of it being used for an open repair.
I've never seen it used for repair other than
Yeah,
that one time, and it kind of caught me off guard. So I was like, okay, I mean, it separated the tissue. It worked fine. I was like, okay.
but it's
I mean,
expensive, and then when they use, it's basically a balloon, right? With it's like a straw, like a really big straw, like a boba straw with a balloon at the end of it. And you put the straw in the space where you want the balloon to expand, and you expand the balloon. It's like a breast implant, right? It's a big expander, tissue expander to make space behind the muscle without having to make a big incision to make the space. That's the purpose of it. It's a great invention. It works very well. It's just expensive. It's like $700-800. And especially if you're working at a surgery center for doing a hernia, you're not even getting paid $700 or $800 profit. So to use that, it's a big drain in resources. Plus the original spacemaker, I don't know if you knew this one, the original one was not latex free.
I didn't know that. I think most of the original instrumentation weren't latex free.
So you had to make something like that with a
Mhm.
latex free glove. Oh, you know
Hence
what?
the
I
toe
have
finger.
the toe finger. I had I'm seeing a patient who had that spacemaker put in and then it popped, but they didn't know it popped. Like pieces of plastic were in him
Oh
for
man.
decades and it got
Oh,
infected and no one knew. He just was always like a little sick and no one could figure it out until he finally got really sick and they did a scan. They saw something where they went there and they saw chunks of plastic in that area. Yeah.
wow. Yeah, those things are hard to, well, I don't know how hard they were to pop back then. They're pretty hard to pop now. Like you basically almost need like
It's
a
very hard to
needle
pop.
or
I don't know
yeah.
people, but I've seen videos on YouTube where people are showing themselves using it. The way you're supposed to do it to prevent a lot of tissue damage is it has a little pumper that puts air and expands this balloon in the tissue space. And you got to go slowly and maybe do 20 or 30 pumps at the most. And I have seen videos where they're pumping that thing like it's some type of video game really, really hard, so fast, and that causes bleeding and extra tissue trauma that's not necessary. And maybe you're
It's
overextending the balloon.
it's like they're using a sphygmomanometer, like trying to take somebody's blood
Yes,
pressure.
it's like it's a very similar pump, right?
Yeah, yeah,
But
very, very much
you're
so.
you're expanding the rectus muscle away from the posterior fascia, and so you need to be delicate in that space.
Yeah, and
Yeah.
when you're thinking you're pumping your Air shoes, your Air Max shoes from the 90s, your Air
Yes,
Jordans,
your
yeah, they
Nike
just
Air Max.
yeah,
Did you
that
have
just
one?
popped. Yes, of course I did.
Oh, of course you did. You're that generation.
Yeah,
So,
I'm a zennial there.
okay, so one thing that I really enjoy with Juan is he's very knowledgeable about a lot of things. Juan is Mexican, and so I love the Mexican culture. I try and practice a little bit of Spanish with him, but I also like Mexican culture and music. So Juan has always
Oh,
been a great person to work with in the operating room because I would let him decide the music for the OR, and I would get like a lesson as to who these people are and what they're singing and the history behind it and so on. So do you still do that?
I try to. Some now most of the doctors here where I'm at, they bring on their own speakers or they put their own music on. But
Yes.
yes, every so often they start playing Spanish music, and I'm like, oh, I know this song, and they would ask me like, how do you know this song? It's like, well, I was born in Mexico, so I grew up with this type of music, and they
Uh-huh.
start asking me. They're the ones that initiate the
Oh,
conversations.
cool.
Like, well, who is this? Well, what are they? Because they don't understand the lyrics. Like, what are they saying? And I explain to them what's going on and who wrote it and why they sing it a certain way. And then
Yeah.
they're like, I didn't know that. Oh
It's
yeah,
so
that's
cool.
awesome. And it's just like they start playing it more and more often.
Well, the
Uh,
thing is, while we're operating on the patient, every surgeon is still different. There are some surgeons they want complete silence, and you can't talk to them. Like they want a complete zen to the max, where there's no discordant discussions, and it's all just the beep beep
and
beep of the anesthesia machine and just focusing on the patient. There are
they don't
other
even
other
they don't even
extremes,
talk to us.
and they don't talk to you. Yeah.
And because of our training, we know hand signals that you guys use for surgeons.
Yes, like scissors.
Scissors, pickup,
Pickups.
suture. Yeah,
Suture.
so
Give me a suture.
that's part of our training. So
Needle.
when we work with surgeons like that, we have to pay attention to their hands because they
Yes.
won't tell us what they want. And all of a sudden, like they just stick their hand out. They do the signal, stick their hand out.
Or someone just stick their hand out.
Yeah, so
Um,
exactly.
which means you need to know what the operation is and what they have to do next.
Yeah. And in the beginning of my career, I remember staying up late at nights researching the surgery I'm about to do on be
Mm,
assisting in, and I was like, okay, these are the steps. This is what I'm looking for. This is it, and it got to a point where I was researching 4 to 5 different surgeries a night, and my ADHD brain works. I tend to memorize things, and
yes.
I kind of memorized the
So I said
rhythm
you're
of the
very
surgery.
intelligent. Yes.
And I was able to keep up with some of these surgeons. Like there was these 2 surgeons back when I was doing my clinicals. They were 2 GYN surgeons, and they would talk between each other. They wouldn't talk to any of us. And usually their cases, they would do like total abdominal hysterectomies, open hysterectomies, and they'd be 2 techs in the room because they were so fast. And again, all what they were doing was hand signals, and we were
But
just
also you can't see very well when it's deep in the pelvis doing a hysterectomy.
no, you can't. And
Those are
then that's
hard to
that's why,
see.
yeah. So one day with them, one of the techs got sick and had to leave, so I was left alone with them by myself, and I have no idea how I pulled that off. But even at the end of the surgery, the doctors were like, "You're like an octopus," because my hands were just moving back and forth between both surgeons, and I was like, oh, "Crap, what am I doing?" I was a student; I had no idea what I was doing.
Oh, wow.
So I managed to pull that off. I don't know how, just magic. But being able to do that, it showed me that I was able to understand different surgeries and be able to pick up working with any surgeon.
Well, that's interesting with your job, which is you do work with different surgeons. It could be the same operation. You get to see it done multiple different ways, different
Yeah.
techniques, different attitudes. Everyone has their own personality on top of that. They use different sutures, different matches, and you kind of have to know how each doctor does it because no two doctors operate the same.
No. No. You could have been trained by the doctor that did the case before you. You're still gonna do
Yeah.
it different, but you found an easier way, a faster way, or you found your way of doing it better for yourself.
Hmm.
And yeah, us as techs, we do have a cheat sheet. We do have like we have your preference card that gives
Yes.
us like our gives us
It's
your
like my recipe
yeah, basically your recipe.
or
And
ingredients for the recipe. Yeah.
right, but we have to know what the case is gonna be, like how you're gonna work it,
Yeah.
and we have to figure that out.
Yeah.
So
So that's interesting because I would say a lot of people who are looking to like, oh, which doctor should I go to? I feel like the techs know really well who's a good surgeon, who's not a good surgeon. They don't see the patient post-op, but they can see the quality of surgery done. Do you want to maybe explain how different surgeons offer different quality of surgery, like how they handle the tissues or the attitude
so
towards like
okay.
their incisions? Even their dressings, I feel
Yeah,
like
oh,
make a difference.
I miss your dressings, by the way. I miss
Aw,
the dressings that you, I don't know if you still do them, but I miss the way you used to
I
do your
do,
dressing.
I do.
Oh, perfect, beautiful. So, today I work with one of our trauma surgeons.
Okay.
He is one of those guys that he just wants to cut. He just wants to get in and start moving.
Saving lives, that's his role.
That's his role, exactly. Uh, and he is because of what he does for a living, he's very aggressive when it
Mhm.
comes to like opening up
Trauma
because
surgeons tend to be. Oh,
exactly. So it's one of those they just want to rip open almost. And when it comes to closing, they're not too worried about like a plastics closure. They just want to make sure that everything is sealed, everything is watertight,
staple,
everything.
staple, staple.
Yeah, exactly. Staple. And then the dressing.
Time.
The
Time is
dressing
of
has
the
to look
essence.
dressing has to look nice because that's what the patient sees. The dressing. But then there's surgeons like you, surgeons like a few of the surgeons that I know, where you take the time, you do the plastic closure, you do the subcuticular sutures, you
Yeah, we
really
have
do
the
take
time because the
time.
patient's not trying to die on us. Yeah.
Exactly. And but see, like this doctor, even though he is a trauma surgeon, these cases were scheduled,
Oh, yeah.
but he takes the same approach as a
You're right.
trauma. He just wants to get
Mm-hmm.
in and get out as quickly as possible,
Mm-hmm.
make sure the patient's okay.
Mm-hmm.
And there's nothing wrong with that. There really isn't anything wrong with that. But when you're also a teacher and you're teaching your residents on how to do things, like if they're not going to be trauma surgeons, they're going to be, you know, regular surgeons, and they're going to go into general or whatever specialty they decide.
Yes.
You kind of want to teach them how to close correctly, how to take better care as to the aesthetics of it.
Yeah.
Especially when the patient might be 17, 18, 19 years old, a younger patient as opposed to like a,
True.
50, 60 something year old patient. Aesthetics are going to play a big part in their role.
Yeah, I mean, I see patients, I'm like, oh, that's a really big incision for the problem that you had. Or I ask them, how much bruising and pain did you have after surgery? Because to me, that implies a little bit more of a heavy-handed surgeon or maybe a surgeon that maybe not as careful.
Mhm.
Um, so I do think techs have a really great insight.
Yeah,
Who
I
should
can
I
tell you
get
a
my
story.
shoulder done with? They can see all the different orthopedic doctors and how they do shoulders, for example, and hernias are the same.
Anything is the same. I can give you an example. I was a few years ago, my mom was having a cyst removed from her
Uh-huh.
facial. Um, mm, don't ask me how I managed to get into the OR where she was going to have her surgery. I just managed to get in there.
Okay.
I found out I asked around who the tech was that worked with that particular doctor.
Oh,
And I
got it,
just
got it,
asked
got it.
him, I was like, hey, can you meet me after work or whatever?
Yes.
Let me buy you dinner and buy you something to drink and let me just pick your brain about this surgeon.
Good. That's very
And
nice.
and they were sorry, they're knocking on my door. Uh and they were what's it called? They were
Well,
accommodating.
really
They they
helpful. Yeah.
they
To
they
get to
met me
tell
after
you.
work to tell me what's who, and yeah, the tech told me, you know what? if it was my mom, I'd go to this surgeon instead.
Uh-huh. Well,
So
some surgeons have a big name and other surgeons are a little under the radar, but they're really good.
yeah, oh yeah, for sure. So this particular surgeon was one of their top surgeons there,
Yeah.
but their closures weren't great.
Mm,
And again, my mom was having facial surgery. So I
there you
just
go.
told her, like, you know what? Yeah, go ahead, have a surgery with this guy, but ask if you can get a plastic surgeon to come in close.
Okay.
And she did. And they managed to accommodate it. And yeah, she got a plastic closure on her face.
Yeah, one of the things I tell my audience is, when you see when you go for hernia surgery, always get a second opinion. It's always good to get a different viewpoint, let's say, from a different doctor and so on. But the one thing that I recommend, and I don't know how to do it, is, I say, okay, find a surgeon that you trust and just kind of trust that they'll do the right thing. But like I kind of know which surgeons are good surgeons and are not, based on seeing them in the operating room or whatever. But I think the nurses and the techs really know the most because they see multiple surgeons, whereas I don't I don't go into other people's operating room when they're doing hernias to kind of see how they do hernia surgery. I don't.
It's not kosher. It's not cool. Because it
Yeah.
feels like you're looking over their
Yeah,
shoulders, just trying
I
to
think
be.
if I go, I actually try not to go. Like there are doctors that are operating and I go in there to say hi and stuff. It's like a country club, right? But they're usually GYN, the urologist. They're not doing a hernia surgery. I feel like if someone's doing a hernia surgery, I specifically, even though I would want to go in there and say hi, I almost like force myself not to, because I don't want them to think that I'm like looking over to see if they're doing it right per my standards. I don't want them to
Right.
think that, so I just don't. And therefore, I really don't know how surgeons do hernia repairs.
It's honestly a mutual respect thing.
Yeah.
Yeah. And the same thing, like, believe it or not, even with us as techs, we do go in and help out other techs to open the case or do whatever.
Mm,
But once we look at their set, like once they start setting up, we tend to just either walk away
yeah.
because it's their table, it's
It's their
their
table
setup, it's
territory.
what works for them is for them.
Yeah. Okay.
However, like when I'm learning a new procedure and there's a tech setting up, I go and I pick their brain about it
Mm-hmm.
and I look at their setups and I was like, I just to get an idea of what it is, what it's going to be like. And then once you do one, you start messing with the setup yourself. You start changing things left and right, and you figure out what works for you.
Okay.
And then, but you as a tech, you don't go like, oh, hey, you know what? It'd be easier if you do this and put it there, and just because the doctor's going to use it, and you don't do that.
Okay.
It's just a mutual respect between techs. It's like this is your setup, this is your case, you're
Yeah.
going to do this.
Yeah.
If you need help, I'll be more than happy to come and help you. But other than that, it's totally your case.
Okay. There's some questions that have been submitted ahead of time. I want to get a moment to go through it. What is the impact of surgical technologists on the positive outcome of a surgical procedure? That's a good question.
That is a good question. The first thing would be sterility. A good
Mhm.
surgical
True.
a good surgical technologist will make sure everything is sterile. If everything is sterile during the surgery, everything goes as planned, nobody breaks really. At the end, there's a much lower rate of infection,
Yeah.
and that to me is a completely positive, outcome. Just
So
the
important.
the the sterility. The sterility is key. It's the number one thing because, and I
Yeah.
learned this today. A third of hospital related deaths is due to sepsis, due
Yeah.
to what's it called,
Infections.
infections.
Yeah.
And if you're in the operating room, we play a vital role in diminishing that.
Yeah.
So if we just see something that becomes contaminated and we don't say it, we don't say it because, oh, it's in the corner, it's like nobody's gonna touch that area. That's not good. That's not being a good tech. So we have to speak up, especially because I've spoken up, especially when surgeons touch something unsterilely and we tell them, hey, you need to change your glove. Like, no,
Yeah.
no, I didn't touch anything. I'm like, well, I still feel more comfortable if you change your glove.
Yeah.
Because we
Well,
have to speak up.
Yeah, that's very, very important. You're kind of like the police of the operating room when it comes to really, but also a good operating room is one where everyone feels safe talking and saying to the surgeon or to whoever, hey, you just looks like you just brushed against a unsterile area, or uh don't, your gloves, there's a hole in your glove or something like that, right?
which happens quite a bit. Because you
Yeah.
don't realize that you cut your glove, you open your glove or whatnot.
Yeah. Yeah.
But yeah, us as techs, we really have to keep an eye out.
How have the competencies required from operating room technicians, technologists changed according to the increased adoption of minimally invasive surgery, like robotics?
Yeah. It's with robotics, it's definitely a learning curve, even for
So
us.
so you had to get trained for robotic surgery?
I had to get trained for robotics. Yeah. So once I obviously at the surgery center we didn't do robotics. Or at least we didn't do when I was there. I don't know if you guys have bought one there yet or not. I've heard
We
stories.
will, yeah, by next year, yeah.
Yeah. So when I went over to the hospital over there when I was in Pasadena, uh, I got trained in robotics. They actually brought in a rep. They brought in unsterile things that we can use, instrumentation, things like that.
Yeah.
And it took me 3 days. They taught me
Mm-hmm.
for 3 days how to set up the robot, how to set up the field, and not just for one procedure, but for various procedures.
Yeah.
Anything from a hernia to a lap app, an appendectomy, a cholecystectomy, and something with
Prostate?
urology, like some of the process, urology, GYN, things like they taught me as much as they could in those 3 days.
Yeah.
And it's a lot. I'm not gonna lie, it is a lot. I'm much like with surgeons, I'm sure you're
Yeah, it's a long process, but um I think you guys are bored when we do robotic surgery. No?
like it.
There's less for you to do.
Well, aside from less for me to do, I'm able to actually look at the surgery and learn what it is that's happening. That way, when it happens again, we do the surgery again, I can actually I learn the anatomy. So I try to pick up on the
Okay, that's
anatomy.
kind of cool. Yeah, you do see it
So
very well. Yeah,
yeah, I try to pick up on the anatomy, especially because let's say another surgeon is doing the case, but he's not doing it robotically. He's gonna go just laparoscopically. I can tell where he's at and what he's gonna
yeah.
need.
What is a typical educational path of surgical technologists, and what are the most challenging tasks they're called to perform? You already talked about your path. What are the most challenging tasks that they're called to perform? Like heart surgery?
Cardio surgery, like there is the cardiovascular surgery, there is definitely a specialized field for them. I have never had the wish to learn hearts.
What about neurosurgery? Or
No,
brain, the brain?
I've done brain surgery. I said, believe it or not, brain when it comes to brain surgery and like neurosurgery and ortho spine surgery, ortho neuro, very similar. And I also remember our spine surgeon that we used to work with there at the surgery center,
Yeah.
how fast we were moving.
Yeah, very good.
And same thing with the neurosurgeons I used to work with at the other hospital. It's the same type deal. It's just you're just paying more attention to what they're doing because obviously the brain is right in front of you. When you see a skull open and you see somebody scooping out a
Oh my
tumor out of
God.
a brain, you're like, oh
Oh
my
my
God, what is
God.
going on? And when I was learning that, all of a sudden the patient started to seize, and I was like,
Really?
the doctor was so calm. And we had ice in the bag, like ice water, like being churned in the bag. The doctor just turned and looked at me. It's like, oh, just give me some ice water. And very calmly, no panic, no nothing. They start putting ice water
Really?
in the brain, and the seizure stopped.
No
And
kidding.
the doctor turned around and looked at me. So whenever you see an open brain and somebody's having a seizure, just throw some ice water. It'll stop.
Okay, duly noted. Only
I'm
in
like,
Hernia
okay.
Talk Live do you learn these lessons.
I, a
If you
lesson I
ever
learned.
see an open skull with a brain sticking out and the patient seizing, ice water.
Ice water works every time.
Ice works for everything. I give ice packs to my patients, so.
I still have the ice pack that I got from you.
Aw.
The
Yeah,
little blue
they're good.
one with the, yeah.
Yeah, they're good. They're good.
Yeah,
I
they're good. I still have it. And one of the other hardest things that we do is trauma, because I
Yeah,
was at a,
trauma, I would say yes, because that can be anything and needs to be fast.
yeah, I was working at a trauma center before, over in California, and I remember the charge nurse told me, "Hey, go pick this case, go put it in the OR." I'm like, "Okay." I no idea what it was. I went, I picked it, I put it in the OR, and then the phone rings. I pick it up, like, yes, like, start opening. I start opening, like, okay, who's gonna be the tech? And then all of a sudden, I see the patient get rushed in. I was like, "Oh, I'm the tech."
Oh.
Crap. So I just finished opening up, started doing all my counts as fast as I
Yeah.
could, and this particular patient had his carotid cut.
Oh,
So
well,
that
no blood flow to the
from
brain on that side.
right, so from opening to counting to actually being already into surgery took about 3.5 minutes.
Yeah.
And I'm counting probably sponges, probably a good 30, 40 sponges. And then I'm also counting about 130 instruments.
Yeah. Yeah. There's no time
And
to do all the stuff you normally do for elective
oh,
cases.
we have to. We as techs, we have to do it,
Yeah.
especially in a trauma, in any trauma.
Yeah. Higher
That
risk of foreign body, what do you call it
objects
when
being
you
left.
lose? Yeah, objects that are being lost in the body.
Yeah. Oh yeah. Oh yeah.
Retained,
And
retained
then
foreign body with
yeah,
trauma.
return. And
Oh
so
boy.
we have to keep account of everything, especially our shops, our sutures.
Yeah. Okay, what are the essential techniques to prevent infections in the operating theater?
Don't touch anything that's blue.
I mean, that's what I tell the medical students, right? Whatever's blue, stay away.
Don't touch it. Because
Yeah.
in any surgery center, any hospital, anything, whenever we open anything, it's always going to be blue. I
Well, I
don't know
think
why.
what's unique with the operating room is everyone has their role.
Hmm.
It's kind of like the military a little bit. Everyone has their role. There's usually a boss, which is a surgeon, that maintains the kind of demeanor of the operating room. You always want to be that surgeon that allows for a safe environment in the OR for everyone who's working there to be very patient-centered and patient-focused. Um, this podcast is focused on hernia care, but I love that you thought about the patients and their need to kind of understand what goes on in the operating room. But if you want to give a couple different tips or advice to someone who's planning on having hernia surgery from your standpoint, what would you say?
Go to Dr. Towfigh. Number one,
Thank you.
go to Dr. Towfigh for sure. Beverly, Beverly Hills Hernia Center is by far probably one of the best surgeons I've ever worked with.
Thank
Secondly,
you.
do your research.
Yeah.
Find out what type of hernia it is that you have. What are your options? And don't be afraid to talk to your surgeon. Don't be afraid to ask him what's going on. Like
Yeah.
what are really my options? Does it have to be surgical? With hernias it has to be surgical 99% of the time, I'm assuming, you
Yeah.
know. So
Well,
like
some surgeons, let me ask you this. This is an important question. Some surgeons, those patients go to them, right? Laundry list of questions. They want a certain, like, let's say, no mass repair, right? And the surgeon kind of makes them feel bad for asking those questions or is kind of rude or disruptive. Do you see that same attitude of surgeon, are they still good surgeons in the operating room, or like does it matter what their personality is versus how their surgery is? Is there a correlation?
I don't there's not a direct correlation because
Yeah, I
I've
agree.
seen it both ways. I've seen it where they are extremely nice, very patient,
Horrible
but it does
surgeons.
not translate to the surgeries. Yeah,
Yeah.
they're like, oh my God, what are you doing?
Yeah.
And then there's other surgeons that are, complete, pardon my French, complete a-holes. And they are just amazing in the operating room. But they're also they go in with a plan and they're like, okay, this is what we're doing and this is what's gonna work for this patient.
Yeah.
And that's what we're gonna do. Period. End of story. I don't care what anybody else says. I know what's best for my patient.
Mm-hmm.
And that's great, being a good advocate for your patient, knowing what you
Yeah.
should.
The ones who have a good plan, plan A, plan B, they come in thoughtful. I think that's a very good point. That's a great way to choose a surgeon, is the thoughtful surgeon.
When you have, plan A, plan B, plan all the way to Z,
Mm-hmm.
you're in good hands, because anything can happen in surgery,
Yeah,
but not every doctor has a plan for what's going to happen.
that's true.
So when you have a doctor that's like, okay, we're in here, this hernia is not what I thought it was going to be.
Yeah,
We got to switch it up, and we're going to switch our approach. We're going to do this, we're going to do that, or we're going to convert it into an open one because that's going to be best for them. And that's when you have a good surgeon. That's when
yeah.
you can have a great outcome.
That's a good point. That's a very, very good point. Yeah,
Hmm.
this was a good hour.
Has it already been an hour?
It's been an hour.
Oh my God.
How fun was that?
Amazing. It was amazing. It was fun, really fun.
Should we do it again?
Oh, I would love to. I would so love to. Yes, most definitely.
You've been great, Juan. I really miss you.
I miss working with you too. I miss you as a person. Like I miss actually speaking to you. I miss just
Aw,
running into you in the middle of the hallway, just talking, catching up.
thank you so much. I've learned a lot from you, and I hope to see you again.
You will. You will. I guarantee
Okay,
you will.
drop by.
All right. Will do. Thank you so much, Dr. Towfigh.
All righty, and that's the end of our hour, Hernia Talk Tuesday. Thank you for joining me. I will make sure, even though we couldn't do this as a Facebook Live this time, damn you, Facebook. I will upload the YouTube video onto Facebook so you can catch up on it. And also know that all these episodes will be on YouTube for you to share and watch and follow. If you like podcasts, please go to my podcast and subscribe and leave a review so that other people can also find us. And you can find both me and Juan on Twitter and on Instagram. I'm at HerniaDoc and Juan is at surgery
SX
SX_tech 84.
84.
Okay, I'll see you around. Say hi to your family.
Thanks, Doc.
Take care.
Bye.
Bye.